emergency department in a cardiogenic shock state. As you're all aware and know, there are different kinds of shock, and it's not always in practical daily clinical practice to divide or separate different kinds of shock state in those patients, because often it can be a mixed one as well, visoplegic and cardiogenic shock, etc. But today we'll mainly focus as an introduction to the next speakers on cardiogenic shock. Patients who have a decreased cardiac output, rise in preload, low SVO2, low cardiac index, and an increased systemic vascular resistance to try to keep the mean arterial pressure as high as possible in the shock state. So first of all, I would like to give you a definition of cardiogenic shock. And as this nice figure from 2019 shows you, it's not that easy to give you one definition of cardiogenic shock. Those are 5 different studies, and they all give you another description of what shock might be and what the different numbers and the different diagnostic or hemodynamic diagnostic tools can be to diagnose your shock. So far, although we have many fancy treatment options to treat those patients with cardiogenic shock, we even lack the most basic question: what's the proper definition? So I think the most common one that best describes what cardiogenic shock is the stage in which profound and widespread reduction of effective tissue perfusion leads first to reversible and then, if prolonged, to irreversible cellular injury. So we need ischemic an ischemic state in the end organ system, and it is actually a system that goes from initially reversible to prolonged and irreversible state, and I'll come back to this later on. So we can talk like hours about the right or the wrong numbers, which we should focus on, but I think the main definition should be that there is a decreased organ perfusion, which will lead to altered mental status, which will rise in end organ biomarkers as troponin or liver factors, a rise in lactate as a sign of anaerobic glycolysis, and a decrease in urine output, whatsoever those numbers might be. If we look at the different shock states with the cardiogenic, we mostly end up with a cold and wet patients. So patients are cold in the periphery because we get peripheral vasoconstriction to keep the mean arterial pressure as high as possible, and the lungs are wet because of decreased cardiogenic output, cardiogenic index. This little figure can help you in making a difference between the different shock states, but as I told you before, it's not always that easy, and mixed situations like visoplegic cardiogenic shock are often the case. So if we look at different terms we need to describe patients in cardiogenic shock, and this has been very nicely introduced and shown by the previous speaker, we need preload, we need a pump function, and we need afterload. And when those 3 systems are nicely balanced, we have a patient that is functioning quite well. But in a cardiogenic shock state, the pump, of course, is failing. We get a huge increase in preload, whether that is the left side, so the lungs, or the right side, the venous system, the abdominal compartment, etc. And we get a decrease in the organ perfusion and hypertension. So this is actually very basically what a cardiogenic shock state is. When we look at the clinics, and probably those are still the most important things we often see in those patients and give us a clue that the patient might be in cardiogenic shock, we have the systemic blood pressure, which could give us a clue, but this is completely different if we have a patient that is used to live on a systemic blood pressure 160 and goes to 90, as compared to a young lady that always has a blood pressure of 100 millimeters of mercury. So it's compared to the normal state, actually, we should interpret those numbers. And organ hyperperfusion, and the most sensitive thing probably to look at is the mottling score at those knees. If you see that there is mottling at the knee, and there even scoring system for this, this is a highly sensitive thing to diagnose shock state. Decreased urine output, increased heart rate, and if you have a patient, or if you are lucky to have quite quickly an invasive measurement tool, then you have a cardiac index below 2.2 and a rise in pulmonary capillary wedge pressure. We also look at biomarkers, and lots of studies are focusing nowadays on those numbers we should look at. So far we don't know what the right number is to know what the outcome and the mortality flip of your patient might be. But some studies show that if the lactate is going above 4.6, that your mortality due to the cardiogenic shock state will be significantly higher. Whatsoever the correct number might be, lactate is probably one of the best outcome biomarkers we have so far to see how profound your patient is in a cardiogenic shock state. So if we dive into the treatment of those patients, and I won't discuss this too much because it will be thoroughly discussed by the next speakers, I always have this scheme in mind. So we have the lungs, the right side of the heart, the left side, and both heart parts have the preload and the afterload, left, right. And it is clue to see with your invasive tools, with echocardiography, with your clinics and so far, to see where the problem in this patient might be. Is it RV contractility? Is the afterload too high due to your ventilation or in a PE state? Is the LV afterload too high due to pressors or whatsoever? Focus on the problem, try to isolate the problem, and just titrate your treatment based on where the problem might be, and this will give you the best key to success to get those patients out of this shock state. As I told you before in the definition of cardiogenic shock state, this is not something that is present and keeps on being present. No, this is a very dynamic process. And this nice paper of Trusdell in 2018 nicely shows you that the cardiogenic shock state is actually a spiral that is coming down towards death. And the main goal of treating those patients is to treat them and pick them up as quickly as possibly into those negative spiral. Because if you will start your treatment, how fancy it might be at this stage, you probably won't end up with a good success, but the success will be much higher if you end up starting your treatment at this stage of the cardiogenic shock spiral. This is probably one of the most important slides of my talk today, and I think one thing we should really keep in mind that the team play and communication in treating those patients is very crucial. If you are a cardiac intensivist or a cardiologist, you probably won't be able to treat this patient just on your own. You need heart failure specialists, good nurses, you need those critical care specialists, surgeons, you need a whole team of shock perfusionists and whatsoever, and that's the key to success. And if you succeed to get such a nice and well-trained team all together on your ICU, you'll probably end up with a successful team and successful management. So outcome of cardiogenic shock, although as I told you before, we have many new inotropes, vasopressors, mechanical circulatory support and whatsoever, mortality of our patients in cardiogenic shock still remains high. And maybe we had a downwards of the mortality slope in those years where the PCI was coming in, but so far the curve is still staying at a mortality of approximately 50%, although we have those MCS devices coming in. And more we see in sub-analysis of studies of cardiogenic shock that the mortality is highly dependent on what the underlying problem might be. Mortality is higher in RV failure patients as compared to LV failure patients and whatsoever. So probably there's no one-size-fits-it-all principle to treat those cardiogenic patients, and we need to go back to the basics and need to be humble that we still don't have a proper patient-tailored approach to treat those patients in cardiogenic shock. So probably this patient disease-tailored approach is still lacking and is the key to increased success to keep this or to decrease this mortality in these patients. So a big step in 2019 was the development of the SKY stages of cardiogenic shock to put your patient actually in a certain group of shock states. So it goes from A to E, and depending on which group your patient is in at the time of presentation, your treatment and your approach to those patients can be very different. Of course, this is a pyramid. A is at risk, E is extremis, and everything in between. So fortunately, we have less patients in the E stage as compared to the A. So this pyramid helps us towards a more patient and disease severity tailored approach. And only since a couple of weeks, actually, or even days, there's an update publication in IYAC and in Journal of SKY about this SKY classification. And I'm happy to give you a short introduction about this updated version of the SKY pyramid. So as nicely shown in this publication, the mortality is highly dependent on the SKY state the patient's coming in. We could think this is quite logical, but many, mostly retrospective studies have been picked up in this consensus update, and they indeed confirm that the SKY stage is correlated with the mortality of the cardiogenic shock patient. So this brings us in a whole new approach. If we put the patient in the correct group, and if we give him or her the right treatment based on the group he is in, we probably can prevent those patients from gliding towards different or higher SKY stages, and we can hopefully reduce the mortality by this disease or state tailored approach. So whether it's on the CICU, out of hospital cardiac arrest, or cardiogenic shock admission on the intensive care, those SKY criteria seem to correlate with the mortality of your patients. So this is actually the updated pyramid that this has been published only a couple of weeks ago, and it seems quite comparable, but as you can see, the colors now move in a grade. So that means that even if within the same cardiogenic shock state, whether it's C or D, we still have different groups or different presentations of severity of those patients. And this figure more shows you that it is, how would I say, it's something that goes slightly from B to C to D to E. So we have to keep those patients very close and have a close look on them, whether they are not deteriorating from B to C to D, etc. So this is a clear message from the SKY. Keep an eye on those patients. Just don't put them in a bed on the ICU and have a look tomorrow, because you will end up from B to D in only a couple of hours. This is another figure that has been added to the updated SKY. So if there is a chronic cardiovascular disease, we probably not use those stages. So for patients in chronic heart failure, but when there is acute on chronic heart failure or acute cardiovascular event, we have to keep in mind that those patients can quickly go from A to B to C to D, and we have to prevent them from updating, if I can call it like this, from different shock stages. So we lose the compensation between B and C, deterioration, etc. If there's an acute catastrophic event, so prolonged cardiac arrest, they always end in E. All other do not enter hospital in cardiac arrest should transiently go to stage C before they end up to E. This is a quite a bit older publication that also shows you that the mortality is correlated with the stage of your SKY admission to the hospital, but that the mortality is significantly higher when your patient ends up at the admission with a cardiac cardiac arrest. And this is, of course, logical, but this is for the first time that we can make different groups between those cardiogenic shock patients and not just all call them cardiogenic shock and treat them in the same way. This is the old SKY classification, if I can call it old, where they try to give you a physical, biochemical, and hemodynamical way of definition for the different stages, A, B, C, D, and E. So I think the physicals are very important, biochemicals are important, and if you're lucky and you do have a PA catheter in situ quite quickly after admission, you can use those as well to put your patient in the correct SKY group. And it's very important that you mention this quite quickly in the treatment process, because this will help you guiding towards the right treatment at the very early stage. This is the new SKY classification, so from A to E, from the recent publication. And as you can see, the clinical, the biochemical, and the hemodynamic parameters are still important, but especially in the A to C, the invasive measurements have been less important, and we mostly rely now on clinical and on biochemical parameters. And many more studies are needed to use those lactate or whatsoever other biochemical parameters and see how we can further look into those studies, what the the correct cutoff might be for going through the different stages of the SKY criteria. Because if you, as I mentioned in the previous definition, lactate is going up to 5, but from many retrospective and a couple prospective trials, we've seen that probably a lactate of 8 is a better definition to go to the extreme SKY criteria. So we'll have to do this for all those parameters and find out in many trials how we can better define those different stages. This is also an added figure, and I like this very much, because I think this very old lady who is smoking and is still 100 years old will be treated very differently when she comes in with an acute coronary syndrome as compared to a 24-year-old myocarditis patient. And so far, the SKY criteria called every patient that came in with a cardiogenic shock patient. So I think it is essential to differentiate the patient who is high risk due to severe shock with poor hemodynamics from a patient who is high risk due to non-modifiable risk factors for mortality. And this is what this figure shows. So if your patient is old, has lots of comorbidities, is in a coma, has lots of organ failure, has high frailty index, that's a completely different patient that comes in with a myocarditis, a cardiopulmonary failure, so based on the phenotype and based on the shock severity, SKY A to E. So I think a SKY E, which is 25-year-old based on myocarditis, is completely different from a SKY E in a patient that's 85 after an acute coronary syndrome. And that's what this figure tries to show us. Look at the phenotype of the patient in front of you, and this might also guide you towards the right treatment. So in conclusion, although many novel therapies in cardiogenic shock are evolving, mortality still remains high and unfortunately stable over the last 20 years. We need to go back to the basics and be humble, redefine the definition and subgroups of cardiogenic shock, and those SKY criteria are a very first start of this. A patient and disease-tailored approach of different cardiogenic shock modalities is the key to success to improve the outcome, and hopefully the SKY shock classifications and many other programs that are currently running and coming up are a next step in this approach. Further research is urgently needed, and I think we should all be very keen to be a little part of this. I'd like to thank you very much for your attention and happy to take any questions later on.